currently something that's part of my practice, so I can speak in generalities about the surgical management of prostate cancer. But my practice is primarily focused on the management of complications from those treatments, like erectile dysfunction and urinary leakage. And so that's something I can provide a lot more nuanced information about. I also do a lot of basic science research and clinical research, much of which includes prostate cancer as well. So I think, to echo what we heard just a moment ago, there are a lot of great options for prostate cancer right now, and there are certainly patients who are better candidates for radiation. There are some that are better candidates for surgery. There are some who are better candidates for medical therapy. And we recognize this, and really the goal is to find the right choice for you. And then when I discuss this with patients, I always encourage them to try to not look back in time and regret their decision. You made a choice on the information that you had in the moment. And so regret doesn't really help you in that process. It doesn't alleviate any of the side effects. You made a decision, and each one of them have problems, and we can manage those and we can help. So try to avoid that if you can, and just recognize that there are pitfalls to each of these treatments, and that our job is to help you through that journey.
For Dr. Mendiratta, we'll go.
Does that work?
Can you guys hear me okay? Does this work? Great. So yeah, this is as much as we talked about Metro and the clinic and UH, we're all on the same team to take care of all of you, and that's what's so fantastic about Cleveland, and coming to events like this really brings it home for us to just see the patient advocacy. As much as we can talk, is just you guys have a community that you can lean into, and that's what we're trying to do and help. And I'm probably the oldest guy on the panel, and what's amazing watching this, it's been almost 20 years, is seeing the evolution of, we were in silos, like medical oncologists would treat patients with advanced disease, and we would never see, our surgeons or our radiation oncologists. But now what is so fascinating is that we're all managing these patients together, from the spectrum of diagnosed with high risk local disease to metastatic disease. We're working with our radiation colleagues, we're working with our surgeons, and we're really focusing on not only turning it into a chronic disease, but survivorship, right? There are toxicities of these therapies, and how do you, as you live long with this illness, how do you manage those toxicities? And that's what's an exciting time for us. And I, as a medical oncologist, focus more on hormonal treatments, other oral agents that can target hormones, and then obviously newer agents such as chemotherapy, targeted therapies, what we call like PARP inhibitors, and then an exciting time with our nuclear medicine colleagues like radioligand therapies, where we can actually target specifically where we think the cancer is. The biggest thing that I really kind of want patients to kind of feel is that we're moving the field forward. I'm more of a clinician, but it's guys like Dan and Scott who are also doing research, who are really changing the paradigms. And it's, for an old guy like me, it's hard to keep up because the changes are happening so much, which is maybe tough for me, but is absolutely amazing for our patients, that now we're able to turn this into a chronic disease. So it's a very exciting time for us in the field.
Well, thanks everybody for coming. So yes, I'm Dan Spratt. I'm a radiation oncologist. So I focus on, giving radiation therapy as, I guess, a component, but I always say first and foremost, I'm an oncologist, or I'm a physician, and so it really, when I'm seeing patients, it's not about recommending patients radiation therapy. Sometimes that's the right answer. Sometimes it's absolutely not the right answer. And one of the sayings that a mentor told me in New York was, if the only patients you ever, if you're a barber and the only patients you ever send me have shaggy long hair, you're going to think I give every person a haircut. But I think, as Prateek was saying, is now we really try to have this multidisciplinary approach. And I think that if you send me someone with short hair, that hair looks good, I'm not going to give them a haircut. I'm going to say, no, this is not the right thing. And I think so really that's been a great evolution. Radiation therapy, as we may get into it, it's changed a lot. It used to be this binary, you either give it to cure or to end stage palliation, maybe of pain. Now it's almost in every disease state to help prolong life or to delay progression. And so it's, the practice now, probably half of the patients I treat have metastatic prostate cancer, and we partner quite a bit with medical oncology. And as the last speaker said, this whole field of radiopharmaceuticals, the Pluvicto, there is so many coming, and now evolving in the U.S. Radiation oncology is almost out of necessity being involved because we don't have enough nuclear medicine physicians in the U.S., and so radiation oncology. So you're going to see in the next couple of years, we're giving things with terbium and lead and actinium and all sorts of things to target systemic radiation therapy. But thank you guys so much for being here.
Thank you. Okay, the first question, we're going to start with Dr. Lundy in the middle again. As I mentioned, we have a group of men that are newly diagnosed in that group. And one of the first question, a lot of the people that come to that group, they ask, what choices should I make? What questions should I ask in terms of deciding, do I do surgery, radiation, as they all talked about the different choices. So my first question to the panel is, what questions should they be asking you when you give them that diagnosis?
Yeah, I think that's a really great question. We could probably talk for 2 hours on that alone, so we'll try to be a little brief. But I think the first reflection upon that is that you should talk to the experts in each of these different modalities before you make a choice. Prostate cancer is not a disease of days, weeks, or months. It's a disease of a longer time frame, and so you have the opportunity to ask questions and gather knowledge and take your time before you make any decisions, and that will, in most cases, be unlikely to change your overall prognosis. So don't feel rushed in the first step. I know that word cancer is really scary, but prostate cancer is in many ways unlike other cancers, and so that is an opportunity for you to learn and to take your time and make a decision. As far as the specific aspects of your care that determine what the right choice is, there's a lot of variables that go into that. The severity of your disease is one, and there are many types of prostate cancer that we see, and the patient in front of us is very anxious because it's cancer, but we don't even think second breath about it because it's low grade, low stage. It's unlikely to ever shorten their life. And so for many patients, the right answer is to not treat that prostate cancer. On the other hand, the idea of having an active cancer in your body might be very anxiety provoking, and it's not our decision whether to treat it or not, it's yours. And so we have to recognize the patient that is going to be up all night not sleeping and anxious, and their quality of life will worsen, even if we think their cancer is not necessarily going to require treatment. We can still understand and recognize that. I think the idea of surgery, speaking in my wheelhouse, is also anxiety provoking. Prostatectomy is a relatively routine surgery at this point, and we've gotten fairly clever in how we do it, whether it's through small holes, whether it's through one medium-sized hole, whether it's through one larger hole, whether it's in the belly, whether it's out of the belly, whether it's through the bladder. There's a dozen different ways to do that surgically. And really the question is, are you safe for surgery? And do the components of surgery that are risky really play a bigger role for you? Maybe if you've had a recent heart attack, we have to consider that because anesthesia does incur additional risk when you've had a recent cardiovascular event. There are, of course, the side effects, and that's where we do a lot of discussion either before or after your decision's been made. Some of these treatments will have a worsened effect on erections compared to others. Other treatments may not have an initial effect on urinary side effects or erections, but over time will have a more expansive effect. And so there's sort of two different trends there. One is, you take a big hit and you recover, and that's typically the surgical approaches, versus the other approaches where you might not have a major effect up front, but over time that may compound. And you may resonate with one of those, but not the other. And so I think it's a really complicated question, but your providers can give you information that's tailored to your specific diagnosis and can help you make the decision that's right for you.
Dr. Spratt, what are the first questions they should be asking you when I do radiation?
Yeah, I would say, I could not agree more. Please take the time to find out and seek out experts in those domains. They may not necessarily be the people who end up treating you, but I think you really need to hear from the experts because things have changed unbelievably. I can't tell you the difference, and this isn't saying that general practitioners do not give amazing care, But I can tell you that the average radiation oncologist treats maybe 30, if you're lucky, prostate cancer patients a year. A specialist treats probably 300. So that's 10 years in 1 year of experience. And the advances in radiation oncology are just, they're incredible. Now some of you I've treated, and it's saying,
I'm one of his patients.
and we just did 5 treatments. We can target, sometimes I'm treating them to 9 different locations with image guidance and stuff. So I think that what I tell my patients, there's 4 main things. Number 1 is, are there any overt contraindications to getting radiation therapy? And there's not a lot of just hard ones, but one is, do you have Crohn's disease? Do you have ulcerative colitis? Is there something that's going on that would prevent that? I would say softer contraindications are I just had a guy the other day, we measure this urinary scoring system. It's a score of 0 to 35. 35 is like you basically are peeing nonstop or barely can pee at all. He was a 34 of 35. So he's straining terribly to pee. Surgery is going to fix that problem, probably. You may pee so well, you'll leak a little, but I can tell you right now, I would rather wear a pad than wake up 9 times a night and having trouble to pee all day. So if he wants radiation, we have to do another urologic procedure, like a TURP or a HOLE-up, or now they've got a whole long list of things, aquablations, etc. So that's just an important conversation. The next is going over, what is your desired side effect profile? About half of men that are over the age of 60 have some component of erectile dysfunction when we see in studies. And so if that's not an important part of your life or your partner's life, one of the advantages for some men is going to be radiation therapy may have less probability, and that's the key word, probability, because you can still have erectile dysfunction. But if that's not important, then that's a factor that may not sway you to radiation therapy. If it's a very important factor, it may sway you towards it. And I think that the last is going to be overall, I call it your intrinsic anxiety or bias. Okay, so it's not even scientific. I can quote you study after study after study, and I may even say, if I were you, this is what I would consider doing. But if in your brain, let's say you had a family member that got radiation in the 1980s for cervical cancer, and they were burnt to smithereens, and it was a terrible experience, and you don't want to do radiation, I'm not here to convince you, right? So I think we don't want patients to have treatment regret. And what is very clear in studies is that even if I show you a study that showed, let's say there's a little more leakage with surgery and erectile dysfunction, with radiation there's some more frequency, urgency, maybe some bowel movement side effects, the men who chose each of those, their overall quality of life is the same, right? Because you chose it. When men have regret is when you saw the surgeon and you didn't know you had another option, or you saw the radiation doc and you didn't know there's other options. So get informed so you can make the right decision for yourself.
Dr. Mendiratta?
Yeah, I mean, they were all kind of fantastic. Before I got into med school, I was a teacher, and my tests would be how well my kids did, right? Because if they did bad on the test, they didn't know the information because I didn't teach them, right? So it's a kind of an analogy of that teach back, right? You hear the word cancer, that first visit, you may have just glossed over anything we said. And then you go home and then you're like, wait a minute, what just happened, right? So teach back, right? My job is to educate, inform, empower you to make the decisions. Bring someone in with you, right? Record, bring a notebook. Those are the patients where at first, some of our residents would be like, oh my God, they asked to record. I was like, that's great, because then I don't have to do my job again, and I will. I'm always happy to do it, but it's a win-win for you, because then you go home and you have the information, right? In the metastatic setting, the more advanced disease, the questions you really want to be answering is, where is the disease, right? Have a clear idea, lymph nodes, bones, what are the local treatments? Because it's no longer going straight to just hormonal therapies. Have we engaged with our radiation colleagues? And then B, really focusing on what is that land map, right? Where's our journey kind of taking us through the different treatments? What are their side effects, right? As much as I can say, this is the best recommendation. You have to be pragmatic about, as we lower testosterone, what are the long-term effects? What is your health issues, osteoporosis, cardiovascular risks, mental issues, cognitive issues? And I think that's where really taking the time to have those conversations and having an advocate for you and just get a clear sense of what we would kind of do. And sometimes it's very overwhelming, but that's what I try to do in that here's what our treatment would be. Here are the different options. Here's where we would engage with radiation oncology. Here's where we would potentially engage with, let's say you are having some complications from prior therapies. You never have complications from any radiation therapy, but if you are having issues with lower urinary tract symptoms, right, we want to be proactive to say it takes a team and really know who that team is. I think sometimes, you think, is there a quarterback? Is there someone doing it? And sometimes us as a medical oncologist can help, but even if you've seen a radiation oncologist, Dan has been fantastic to engage with all of us and say, here's who you go for the medical oncology, here's where you go for ongoing urinary incontinence, right? So it's really figuring out who on your team can help manage what. And I can't stress enough that do not rush into decisions. You're not on a cardiac cath lab where they're having to put a stent in, right? We have the time to make the decision, and you want to have a clear pathway of what those decisions are, what the side effects are, what are the ramifications. And sometimes you think it's just making one treatment, but as they mentioned, this is not a sprint, it's a marathon, right? So every single treatment you engage, you want to be thoughtful. Are you going to be able to use those other agents down the road, right? So I often have those conversations where the PSA can paralyze you, right? So you're seeing the PSA go up, and I may be saying, look, there's really no need to do anything as of today. And that's a harder part of the conversation. It's really PSA, symptoms, and radiographic, and it's usually got to be 2 out of the 3 before I pull the trigger. I only have a couple of ACEs in my deck. Those ACEs are becoming more and more, but I want to be thoughtful when to use those therapies. And so it's just really having those conversations with your provider and just feeling peace of mind. And, I've done community oncology, I've done academics, and there's nothing wrong in asking for a second opinion from the experts like Dan kind of mentioned, because things are changing and you want to make sure, if it's your loved one, if it's you, you're getting all the information. And most doctors are going to take that as a win-win because A, you're getting the best care, and B, they're getting validated in their treatments and they can come up with a good treatment plan. And sometimes you learn, as we're learning every day, as these new changes are happening.
Just to echo that, I would say even amongst experts, if they ever say don't get another opinion, that's a red flag. There's no qualms. I can tell you right now, there's things that I do. I could send you to 5 colleagues around the country that may give slightly different recommendations. And there's, some of it is for radiation, what equipment they have available. Maybe it's the era in which they practice. Some of it, there's just no difference. Like some of the surgical approaches he talked about, there may be no different, but if that surgeon's amazing at one, you don't want them to do the other, and vice versa. So it's good to get that information.
That just answered one of my questions here. I was going to ask you a second. Do you want to answer the second question, the opinion question as well? I was going to ask about second opinion, but
Oh, yeah, absolutely.
Typed in, you might as well get your...
There's no reason to not get a second opinion for all of these things. Even if it's the same words echoed by another provider, that adds value to you. It adds value to your initial provider too, because then they're validated in their opinion, and your ability to, was that me or, sorry?
That's AI trying to join the conversation.
Hey, Google, what should I do?
Exactly.
Should I get a second opinion, Google?
Google is really wonderful for second
I bet it will say, hey Siri, should a patient get a second opinion?
And so oftentimes we'll discuss that. We'll provide names of other experts in our field at our institution or otherwise, and recommend that a second opinion be obtained. And I really feel strongly about that. And if they choose to follow the provider who they obtained a second opinion from for their care, great, because they were more comfortable with that provider, because the provider offered something different or contrasting. I train residents and I try to tell them frequently that there's no room for arrogance in surgery or in medicine. And so you have to be humble, and sometimes you realize you might not have given the perfect answer to that patient who sought care elsewhere. And you know what? You can learn from that. And so Absolutely. Second opinion, even a third opinion, don't be paralyzed by them. Like 7 is probably too many, but get a few and then go with the person you're comfortable with.
Thank you.
Oh, actually, I want to say one more thing. Sorry. There's the same thing about knowledge, too. Like, there should be humility in medical knowledge. The Nobel Prize was given to Huggins for identifying the role of testosterone in prostate cancer for one patient back in the 1940s. We now know that some patients with advanced prostate cancer can receive testosterone and can do very well with bipolar androgen therapy. So we don't know everything. We're still learning too. And that humility and that evolving knowledge is what's so exciting. Sorry.
That's right. The follow-up I was going to ask before we got into second opinions. We talked about that first-time diagnosis and what questions should ask. However, we all deal with the idea of reoccurrence. Whether it comes back in a year, 5 years, 10 years, that's always something that's kind of hanging over a lot of our heads, watching for possibly reoccurrence. When that reoccurrence happens, what questions should they be asking? So I'll start with Dr. Mendiratta. What questions, when you come in with reoccurrence, should we be asking?
Yeah, I think it's very similar to what we kind of already talked about, right? So it is a frustrating and it's so hard sometimes to just mentally get over the fact the surgeon told me it was going to be cured, or the radiation doctor and the hormones. And so I'll be honest with you, in a lot of those visits, sometimes it just takes 1 or 2 visits to just, we're here. And I can only, as I've done this over time, it does take a little bit, because I just got to give the patients grace to say when they get there, right? And so once you've kind of accepted that, okay, we're at this situation, it does not change if anything, some of our studies have shown that patients who come into the office or the hospital with pretty advanced disease, widespread metastatic, multiple bones, very high PSA, those patients are the ones I get worried about. Some of our patients who have recurrent disease now, it could be many years from their initial therapy. We can sometimes even just give local therapy and sometimes even spare them of hormones, and they can have a very, very, very long course. So not that I would want anyone to have recurrence, if you get what I'm saying, but these patients do much, much better than patients who come into my office with very advanced disease. So I think it's 2 parts. One, just mentally getting over the fact that unfortunately cancer is back, but focusing on the positive, that we have many treatment options that we can address. And nowadays there are clearly studies even showing that isolated radiation, plus or minus very low doses of, or low time, I shouldn't say, can't really modify the doses of some of our therapies, but short course, hormonal therapy or even no hormonal therapy is a nice option for those patients. So recurrent disease is no longer something that I feel really is, it's very different than someone who comes into the office with very aggressive features.
Dr. Spratt, reoccurrence?
Yeah, so, one point, I just want to say that I think we, and I'll say we as everybody in this field, we don't always do the best job. And let's say a patient decides to undergo surgery. We as a field, right, you guys may have heard the term salvage radiation. And salvage is like, so we finally, in the national guidelines, we've now termed it secondary radiation. So it's still SRT, salvage radiation is now secondary, because it makes it sound like we're salvaging some botched job that the surgeon did. But if you look across cancers, so as a radiation oncologist, there's almost every cancer in the human body we treat, almost. You will either get radiation before or after surgery, or it might be chemo. And it's simply that cancer, right, if it was just simply like a little golf ball you scoop out, no one would die of cancer. Surgeons would just cure every cancer. And so it's more so that that's an important, like I say, the success of surgery is if you have acceptable functional outcomes and it was in safe surgery. The biology of the cancer may dictate, not the surgeon themselves, again, assuming they're a well-trained, experienced surgeon, that you may need radiation after. And so what we've moved towards is, years ago, we would just reflexively give people radiation after surgery like you do in breast cancer. You end up over-treating. Surgery does cure men. So you're just blindly giving radiation for no reason. So now we monitor that PSA closely. And the recommendation now is to give what's called early salvage or early secondary radiation, like PSAs of 0.1, 0.2, 0.3, when it's really low. And the cure rates actually are quite high. And you save the men who don't need the radiation therapy. Now, we have a new term, people will call this second BCR, second biochemical recurrence. You've had surgery, you've had radiation, but you recur again, right? And you almost always in that setting, it is very uncommon that the cancer is actually in your, we'll say, pelvis or your prostate area. Okay, because surgery took out 99% of it, radiation usually gets rid of that last bit, but it means there's probably cells in your lymph nodes or somewhere else. And so at that juncture, it becomes really important to be getting some of the imaging the last speaker talked about, the PET imaging, to be tracking something called your PSA velocity or doubling time, because you may, it may be something very indolent. It may sometimes, unfortunately, be that that's when we identify metastatic disease. But overall, if you just took 100 men that recur after surgery that we're going to give radiation to, some of the longer-term studies, it's only a couple % of men 15 years later die of prostate cancer. So even though it's recurrent cancer, it definitely doesn't mean that this is something that's, everything's a bell-shaped curve, but yeah, as Dr. Mendiratta said, some of these men do exceptionally well. And the last point is, some of these men, they'll recur 5 or 10 or 15 years after surgery. I usually don't even necessarily treat them. I have a guy we've been monitoring him. I haven't been doing this for 25 years, but I monitor him the last 10 years. He's 25 years out from surgery, and his PSA doubles every 3 years. And he now, 25 years later, he's like, 87 years old. He's got a teeny little, I call it a wart. It's like a little pebble that's growing slowly. He doesn't ever need treatment. It's some low-grade cancer that's just growing, doesn't need to be treated. So recurrence, we may not even treat you, but we'll risk stratify.
This is a great conversation. This is fun. Couple things. So first, I don't know that any surgeon can ever tell you that they've cured you in prostate cancer.
Or radiation.
Fair. I'm just going to dog the surgeons, though. We can do a good job treating your prostate cancer, and we can get that PSA to 0, and we can keep it there. But prostate cancer is sneaky, and so we watch that PSA for a reason, and that's because we know that even if we think all signs point to a cure, we still have to do our homework. And so, there are often patients I meet who are surprised when their PSA is 0.1 or 0.2, and I say, well, maybe there's something back now. And they say, but I was cured. Well, maybe not. And that's okay, because we can manage that. The second thing is there's a tool called PSMA PET that we heard about earlier that's really changed this landscape. We used to have to wait until things were pretty ugly on certain imaging studies to be able to identify a true clinically significant recurrence. We now have this really sensitive test that can help us identify lesions. Well, all of a sudden now, because of that test, we see much more recurrence in certain places than we did before. And that doesn't mean that we need to treat them like we did the more significant lesions that we saw before this test. It just means we have more information, and we have to learn how to handle that information and what to do with it. And sometimes we just watch it because it is, in fact, not clinically significant. But that's an important caveat, is that with our evolving technology, we can't always rely on the older studies to answer these questions. I will say there are some challenges to treating a recurrence with one approach after another approach. There's usually no deal breakers. And so, if a patient had radiation and then comes back to the surgeon with a recurrence, and we have a discussion about a salvage, although a secondary prostatectomy, that's reasonable, yeah. There are some challenges to that surgery. It requires a surgeon who's comfortable operating in tissue that's had radiation before. There's probably an increased risk of some challenges with that surgery as a result, but it is now something that large academic centers like UH and the clinic are doing. And so we have options, but we have to choose the right option for you. And I don't know if I would necessarily make the decision on treatment path based upon the potential theoretical need for a repeat treatment down the road. I mean, it should be a sliver of your decision making, but that's not the primary decision point in my mind, at least.
Thank you. I do have a few other questions, but also watching the clock, I want to open it up to questions you might have to ask the panel. So before I go on with my questions, does anyone have a question they'd like to ask this panel? Don't be shy. The way in the back.
It's more of a comment. I was diagnosed with what used to be called, or still is, juvenile diabetes in 1962. So I've had it for over 63 years now, and I've lived with that. And then obviously the prostate cancer came up. But I wanted to just comment quickly. I feel it was unfair to call any cancer or prostate cancer a chronological disease, because I know what it's like to live with this diabetes, even with all the changes, because without insulin, I'm dead. So I don't know if it's a fair comparison, and obviously every individual person that might have prostate cancer or diabetes, whether it's type 1 or type 2, or medically induced diabetes for some reason, they're all individually different. Sorry, I thought I'd bring that up.
Yeah, so first of all, that's an excellent point. So we'll often say we can turn, we'll often say metastatic prostate cancer, which, it was a fatal condition. Now, 1/3 of men with metastatic prostate cancer actually live long enough to die of something else. Not everyone. So turning into a chronic condition like diabetes or high blood pressure is nowadays, not that many people die of high blood pressure, just a hypertensive crisis. It happens, but it's usually you're managed, you may diet, exercise, add a drug, change the dose, add another drug. And really can we now do that in prostate cancer so you can live? And so, we will all have these anecdotes, but, I have a patient who's 11 years out. His PSA was 6,000 initially, and he's been on and off, multiple different systemic therapies, and we've been doing, people call it spot welding. We've been treating some of the metastases. And this won't work for every patient, but, that's 11 years when he was given 3 years to live. So it's a chronic condition that we're kind of like your blood pressure or your blood sugar. We're using that PSA and the imaging. Of course, we'd love it to be a binary, cure, but sometimes for some men, it is actually, you can have a detectable PSA, you can have active cancer, but do everything you want to do. There's also, like in your case, I'm sure there are cases that you are suffering greatly from the treatments themselves, and so it's not just simply you're alive, asymptomatic. So, but it's a great point.
Sorry, in addition, so my own personal question for my sake and my wife. My latest PSA was 0.33. It's been way below 0.5 since the end, or 6 months after the end of my radiation. I've had 45 nonstop days, weekdays, 5 days a week of radiation treatments. Is 0.33, does that mean it's stable, or does that mean it may come back?
So without knowing a lot more about it, what I would just say in generality terms, so number one, if you don't mind, when did you finish the treatment?
When did I finish?
Yeah. Like, is this year, last year?
2023.
20, okay, so it's been a couple years. So in general, so one of the differences after surgery or radiation is, so surgery, right, will remove the benign, or if you want to call it healthy prostate tissue, so you should really have no PSA functionally, or really, really low levels, if any. With radiation, I tell guys your PSA usually should end up below 1. Sometimes it can be 0.5, 0.3, 0.2, 0.1, but usually less than 1, because your normal prostate still will make some PSA. So without knowing anything else in trajectories, I would say that is very common, very normal to have that PSA level.
Anyone else want to comment?
What about that same line? So is PSA follow-up enough? Would you feel comfortable if your PSA is, at a good range to say, okay, you're doing well, or do you need other kinds of, tests?
I think it's a good question. I think PSA is not a great test to initially identify prostate cancer, because so many men have elevated PSA from an enlarged gland or from inflammation or other reasons. I think PSA is a really good test after treatment in many ways because we can trend it and we recognize that we now have a diagnosis and changes in the PSA can tell us something valuable. And so it is a good test in that regard, and it's probably the first line test that we have. But when we see something on PSA or other clinical signs, there are absolutely roles for other ancillary tests to help identify what's going on. But I don't know, I don't see PSA going away as our first choice for surveillance anytime soon.
Yeah, I mean, this is the bane for all the companies out there that have all these really cool liquid biopsy tests and all this stuff, is PSA is what every cancer wishes they had. So it is, as you said, I call it a so-so test for diagnosis. It's exquisite for monitoring after initial treatment. That is different, and we have Dr. Mendiratta talk in that in advanced prostate cancer, we have times where the PSA does not reflect progression. So I don't know, Prateek, if you want to...
Yeah, in the metastatic setting, I think it's to Dan's point, in the patient who had surgery, it's actually very helpful because the PSA should be, virtually undetectable. In patients with radiation, sometimes after they get local therapy, they're always wondering what is that threshold. We usually take the lowest it gets and then add 2 to it. Obviously, that's a moving with some of our new imaging. But in the metastatic setting, my job on that first visit is to just try to detach all value on the PSA. It's just like I'm seeing your vital signs. It's just one of the components of the stories, right? So really, when I look at patients, it's how are they feeling? How are they feeling with the side effects of the treatment? What that PSA is doing, I don't ignore it. And then we take it with imaging. And nowadays, getting, obviously, now it's looking at trying to individualize the treatment, getting genomics, getting germline testing, right? Things that you are all in every cell, and then specifically in the tumor cell. And all those things make a difference. We have seen patients where PSAs go up and down, and if we responded just to the PSA, we could have started them on treatment, and 3 months later, the PSA would have kind of come back down. There's a lag time. In certain patients, it does correlate, right? So if I see a PSA going up and they're not having symptoms, I usually say there's a 3 to 6 month in the advanced disease before you start seeing stuff. So we have the ability to kind of use the PSA as a tool, but it's not the end all be all in the advanced setting. And a lot of studies now have really stopped saying, yeah, we want to see PSA decline. We all want that to happen. It usually tends to be a better predictor of patients who do longer, but we don't always change treatments if the PSA is not going in the direction. We give it time. And it's just one of the tools that we use before we make decisions.
I have a question.
Okay, we have a question.
I have a question, actually, 2 quick questions. One is, I'm a cardiologist at the clinic, and I was sort of surprised of the discrepancies of the diagnostic tests. In other words, when is there a discrepancy with the biopsy, like the Gleason score, and when you take it out if you did the prostatectomy? Yeah. So I was very fortunate my Gleason score was a lot lower than based on the biopsy. That's one thing. And the other thing, could you just comment about the post-urinary incontinence options for a busy person?
Yeah, so first to kind of bridge those 2 discussions, there will inevitably be a discrepancy in some patients, and that's because Gleason score in particular is not a great description of a cancer. It's a histologic pattern on the microscope, but that doesn't tell us what that cancer is doing on a molecular level. It can be much more aggressive or less aggressive. We do know now there's a pattern called cribiform that I think is really important that we use, and that's a factor that's sort of independent of the Gleason score that helps us. But from a PSA perspective, it highlights how different our practices are, even though we're still very specialized, because you're right, it's important. And there are cancers in the prostate that don't make PSA. So we used to do biopsies, and one of the arguments was if a PSA-independent prostate cancer happened, they're very rare, but they can be very aggressive, and we would miss them by looking at PSA alone. And so there is always a discrepancy there. And I think when we talk about a biopsy, historically we would blindly put a needle into a deep, dark hole, and we would be lucky to find a lesion, but we might have, just skived on the side of that lesion. The MRI has helped us a lot in that because we can now see a lesion and go after it. But even that's, these lesions can be very, very small and very difficult to target. And so some of the discrepancy is likely from some technologic or technical aspects where we can't fuse those ultrasound and MRI images perfectly. We get close, but we don't, strike the actual lesion, if that makes sense. From a urinary perspective, particularly with surgery, there's going to be some leakage after surgery. And there are technical improvements in the different ways we can remove the prostate to lower that. Nerve sparing can certainly play a role there, but men should expect some degree of leakage after surgery. You can, ahead of surgery, if you choose to go that way, do Kegels and other pelvic floor work, which is really important. After surgery, you and your provider have to be patient because there will be an evolution in those symptoms over 6 to 12 months where initially that leakage is torrential and then it gets better and it starts to lessen, and instead of saturating diapers, you're saturating pads, and then you're only using pads for drips, and then you're using pads for protection for some people. And so patience is important, and I recognize how hard that is it's easy for me to say that, but the body can in many cases help itself. If that's unsuccessful, our two main options for intervention are going to be a sling or a sphincter, and they each have a role. A sling is, generally speaking, best for patients who've not received radiation, who have low amounts of leakage, like a couple of pads a day at most. A sphincter is good for people who have torrential leakage and may or may not have had radiation, and both of those solutions are quite good and can get patients to near continent. Now, we typically say you should expect a single pad a day as protection, so we don't want you to be, we want you, but we can't necessarily predict that you'll get to exactly where you were before surgery. But both options offer a lot of value. One final sort of peripheral option, if climacturia is a problem, where during climax there's leakage of urine, first, that is not nearly as catastrophic, medically speaking, as it does maybe seem like. There's no major health concerns with that, and some couples are able to resolve that mentally and cognitively and move on. But we can put a little sling on at the time of a penile prosthesis, for example, and when the prosthesis is opened and activated, it pinches the urethra off and prevents that from happening. So we have a lot of options, and there are some other options that are on the horizon, and some we found that don't work so well. But it's certainly a big part of quality of life, and certainly something that we work with patients to find the right solution for.
Thanks. So say a parent has had prostate cancer and they have sons. So should the parent get the gene check and then have the sons get that also, or what kind of process should be followed in that case?
Yeah, no, and it doesn't always matter just because I'll have, they'll bring in their wife or they'll bring in their daughter and they'll say, well, we don't have to worry about it. But it is a continuum, right? And so this is where I usually say it's so important to get that germline testing, which remember, that's every single gene, right? Every single cell is going to be able to test that. And the best thing to do is not just test the whole family, but just test the patient, the one who has the cancer. So you do germline, and now with liquid biopsies, we can also do cancer testing. So if that patient is positive, then what we do is we do, especially if it's BRCA1, BRCA2, there's genetic counseling that will meet with you and talk to you about testing, because not only is it just prostate, pancreas, breast, it's a continuum that you need to educate your family about. So we're pretty pragmatic about, and now it's gotten to a point where even patients who present with high-grade local disease, the guidelines are stating to test those patients up front. So there shouldn't be a reason in today's day and age to not sequence everyone's tumor and looking for germline. And I don't recommend just all of a sudden every family member get tested, because if the patient is negative, the likelihood that that's going to be in the other generations are going to be very low. So I would just start off with testing the involved patient.
Yeah, and just to, Dr. Mendiratta said it, but so right now the guidelines, if you have advanced prostate cancer, metastatic disease, everybody should get testing. If you've got high-grade non-metastatic disease, they recommend testing. But if you have a low-grade or intermediate-grade cancer, you need some other factors to prompt testing, okay? Because only about 10%, so let's say you have prostate cancer, only about 10% of the time that's going to be hereditary in nature. Prostate cancer, right, is just so common. 1 in 8 men, if you take African Americans, 1 in 6 men. So the odds I always say, if you have breast or prostate cancer in your family, it's really, really common. The odds are it's not going to be genetic related. But so if you have low risk prostate cancer, you can get these commercial tests. So sometimes you just like information. I'm not endorsing this company, but a company that many universities use is called color.com. It's just direct to consumer. It's $250, and so you can do it. But as Dr. Mendiratta said, you don't need to test your entire family.
Dr. Lundy, comments?
No, I think an 85-year-old who's diagnosed with prostate cancer and it's low grade is a very different patient than a 40-year-old. And I've seen a 40-year-old with a PSA of 1,500, and that's the sort of patient where genetic testing really comes into its own. So again, it's personalized. If you're the type who likes information, as long as you can contextualize that information, there's no problem with it. But it's going to be difficult to potentially interpret that information on your own, so you want to rely on your providers with knowledge to be able to put it in the picture for you.
Sandy, one time for one last question. Oh, my two people answer. Got to do that. Bob and two last quick questions.
Okay.
Recurring prostate cancer after 9 weeks of radiation, is hormone therapy an ongoing thing? Is it a temporary thing? Could somebody talk about hormone therapy? Thank you.
Well, I'll first talk about, so number one, just to put the plug in for if you're getting treatment in a modern time frame, hopefully you guys aren't going forward. The past is the past, and we were doing like 9 weeks. Hopefully you're being recommended 5 or maybe 20 treatments. So times have changed. Second is recurrent prostate cancer. Actually, the most common is you need to figure out where it's coming from. So now it's very common. We do what's called re-irradiation. We do a lot less, I think nationally, going to remove your whole prostate. There's other procedures you can do if it came back in your prostate. If it came back somewhere else, that's where this PET scan comes in, that's where we would do, targeted radiation therapy, potentially with hormonal therapy. Very few men, the only patients right now, it's actually the preferred treatment for men with a rising PSA after radiation therapy is just monitoring until the PET scan can show something. There are some exceptions if your PSA is going up extremely fast. We call it the doubling time, where hormonal therapy, we say, look, it's going up so fast, let's put you on it. But I would recommend, don't let that PSA just be, an anxiety provoker to just hop on hormone therapy, because it won't cure you of your cancer. It may control it, but we want to know where it's coming from to potentially better target it.
Yeah, no, I echo the same things. The PSA, like I said, in all different disease states can paralyze you. And just because we have an option such as hormonal therapy, I've had many men on hormonal therapy who've had a lot of complications. And the goal is really to use the right drug for the right patient at the right time. I know it's a simple saying, but just being thoughtful about when we use it, how we use it, and really try to limit. The paradigm is switched. Once we saw recurrent disease, metastatic disease, we would say lifelong hormonal therapy. They would have then complications of strokes, cognitive issues, and that is now completely switched, where we're actually trying to get them off hormonal therapy and just working like that spot welding kind of approach. And I've had many men go 6 months, go take breaks, treat areas, and the goal is to really minimize, because I think we were just focused on getting the PSA down and not worried about survivorship. There are severe toxicities, and as you get older, even these other agents that we add, survivorship is important, right? And we don't want to cause any harm in our patients. So.
Yeah, I want to expand upon that a little bit. I hope, with respect to my colleague here, I hope it'll make your blood pressure go up a little bit. But so hormones are a complicated thing in prostate cancer. We know now with relative confidence that, we know with confidence that testosterone therapy does not cause prostate cancer. We know that there's a large subset of men with prostate cancer that we can actually give testosterone to and they're going to have a better quality of life, and their disease is not going to rage out of control like we once thought. So I'll routinely give testosterone therapy to symptomatic hypogonadal men after a treatment that appears to be effective, and we can monitor their PSA because it's a good test. We'll give testosterone therapy to selected men on active surveillance too, as long as they're being monitored and we have that discussion about the risks and the benefits ahead of time. Now, logically, there's somewhere in there is a flip, right? Because we know ADT and hormone blocking works for advanced prostate cancer. So we can't give testosterone until the moment we take it away. But we're evolving our knowledge in this area greatly. And from a quality of life perspective, the word testosterone is not a dirty word when it comes to prostate cancer. We just need to learn more. And in our research, we're studying this. We now think that there's an anatomic pathway for testosterone to follow from the testicle to the prostate. That's been there for decades, and we just found out about this. And so we're still learning, and there's still avenues for us or aspects of this care that we don't fully understand.
Thank you. As much as we can keep going on, my prostate wife over here tells me that we do need to stay on track schedule, so not here too late. And this discussion really can keep going much longer. I know a lot of people have got questions, and I appreciate it. I want to thank the three of you for participating today. I hope you found it as interesting as I did. You always learn something every time we have one of these doctors speak or have these kinds of discussions. But you can see prostate cancer treatment is progressing, and there's always something to learn in every presentation.